Good morning, everyone. So this is a case of a 68-year-old male who presented with complaints of diminution of vision in left eye from 5 days. He had a systemic history of type 2 diabetes mellitus from 23 years and cardiovascular disease from 7 years, for which he got bypass surgery done 1 year ago. And he was on antiplatelet medications, and he had an ocular surgical history of cataract surgery in left eye from 2002 and scleral buckle surgery in the same eye in 2018. His best corrected visual acuity was 612 and 6 in right eye and 618 and 10 in left eye. Intraocular pressure was 12 in right eye whereas 20 in left eye. Anterior chamber was deep in both eyes. The PCIOL in right eye was well in place, but it was decentered in the left eye. Therefore, OS IOL exchange and iris claw IOL implantation was planned after getting clearance from the cardiologist. The surgery was done, and post of day 1, it was seen that the AC was quiet and IOL was well in place, and he was asked to come after 1 week for follow-up. But the patient presented to the emergency on the day 5 with complaints of pain and headache. So it was examined, and it was seen that the vision dropped to PL inaccurate, and the intraocular pressure was 4. The anterior chamber was shallow, and there was vitreous in anterior chamber. And we can appreciate large choroidal mounts sitting right behind the intraocular lens. So B-scan was done, and multiple hyperechoic dot echoes were seen in all the quadrants with moderate to high scan spikes. So left eye suprachoroidal hemorrhage was seen. It was a delayed suprachoroidal hemorrhage. Therefore, the patient was conservatively managed, and as we know, according to the literature, we have to wait for 1 to 2 weeks for the clot lysis to occur before intervening. So we waited for 9 days, and on repeating the B-scan, we observed that the clot lysis has occurred. So we planned a suprachoroidal hemorrhage drainage under local anesthesia for this left eye. So an AC maintainer was placed, and trocas were placed 5.5 mm away from the limbus, just entering tangentially into the suprachoroidal space, taking care not to damage the retina or choroid. And it were placed in the quadrants with the maximum choroidal mounts seen from the B-scan. This is the immediate post-op picture showing significant reduction in choroidal mounts, and B-scan showing the same. This is the post-op day 11 picture showing a complete resolution of choroidal detachment, and the vision improved to 618. The intraocular pressure was 24. AC was deep, and as you can see, there is no choroidal detachment. And on the last visit, the vision improved significantly to 612 and 6, and intraocular pressure was 18. AC was deep, and the iris claw IOL was well in place. So there are a few learning points. Like in such cases, B-scan ultrasound is the most important investigation. Intervention for suprachoroidal hemorrhage should be planned after the clot lysis, that is at least 7 to 14 days. And surgical outcomes are variable, but prompt intervention is the key to achieving success.
Good morning all. Thank you Arman for the presentation. This was the case which Dr. Arman has presented. The sole reason for presenting this case here is that the relative rarity of the presentation, usually following an uncomplicated iris claw implantation, we rarely come across this kind of a presentation. And even in literature search, we were unable to find any single correlate like this. So this was managed by conservative standards, nothing very heroic about it, but we were lucky, and so was the patient, that following minimally invasive intervention, the patient did recover good improvement clinically as well as vision-wise. When we went back to the literature and looked into the success rates of suprachoroidal hemorrhage drainage, it says that the improvement and the visual acuity improvement is generally not seen in about, is seen only in about less than 10% of patients. Luckily for us, in this patient, at least that was not the case. And to our surprise, and as the patient actually did very well on the day 1 itself, you can see with the improvement in the B scans. from the pre-operative huge mounds. The vitreous cavity is completely cleared, and we were able to actually achieve a good post-op optos photograph on the day 1 itself, which showed significant improvement. And gradually, as the time went on post-operatively, the patient tended to improve from there on. And at 3 months' time, as it was mentioned, the patient maintained a visual acuity of 612 N6. It only goes to highlight that every case is not a lost case, and if we intervene correctly in time, probably we may be able to achieve some reasonably good outcome for the patient. Thank you, COC, and thank you, Dr. Meena, for the opportunity.
I thank Dr. Arman and Dr. Jyoti Prakash sir for the case presentation. Now over to you judges for the panel discussion.
Actually, this is some bit of a new information to me, because whenever we learn that expansive hemorrhage or choroidal detachments occur, they should be managed as fast as possible before the retinal detachment portion is delayed. So you are saying you should wait for clot lysis in the posterior segment.
Yes,
But suppose the IOP had risen up, or suppose you were not able to manage with that B-scan. I mean, it is good for you that it subsided and it was stable, but if it wasn't, you would still wait.
In that, the intervention should have been earlier.
Yeah, expansive hemorrhage, the general learning is that you should do it, you should drain the fluid. So I'm a little...
No, but ma'am, this is not intraoperative. It was delayed
Right,
post-operative.
even
On
then,
the day 1 post-op following the iris claw implantation, the anterior chamber was well deep and seen by the primary surgeon themselves, and the air bubble which was there in the anterior chamber was seen to be freely moving. So there was no reason to anticipate such an occurrence in this case. It was a surprise when it presented on day 5.
It came up now, true, but that was probably the secondary hemorrhage or something happening.
Yes.
But if that is happening and it is becoming rapidly shallow, there are only two possibilities. One is malignant glaucoma occurring, and the second is, of course, when you did a B-scan, you saw this.
Yes.
So if you see this, should it be drained? I mean, why should we?
If the intraocular pressure was high, definitely we had to intervene earlier. But then we needed a place to enter the vitreous cavity, which was not possible. So that is why we went just for the clot lysis to occur, and then we went ahead. And IOP was on the lower side, so that worked for our benefit.
Yeah, if you have daily monitoring and you see
Yes,
it, and you have a B-scan with you, which you can do hourly, then I suppose that is good.
Yes,
But
the
then
patient
you
was
have to point for
unfortunately
this
from
case.
quite far away, and that's the only thing.
I would say that an excellent result
Yes, sir.
warrants that you have done really well. But what was the mistake?
That is the only thing, sir, which we were
Expressive is not your
pinpoint.
mistake.
No, sir. This case was just presented for the rarity of presentation and the relative good outcome which this case had.
So I would say that we have to wait for 10 days for the resolution of for clot lysis. If it occurs intraoperatively and the mount is coming, and if it is a cataract surgery, probably you would want to just close the wound and get over with it. But as a retinal surgery, if a retinal surgery is in picture, probably intraoperatively itself, you could look at draining based on an indirect ophthalmoscopy, where is the maximum amount, because now the blood is still in a fluid form. But then after some time it will completely clot, and then even if you drain after 2 days, nothing will come out because it's a clot. And clot lysis would occur maybe at about 8 to 10 days down the line, and that is why at 10 days we plan the removal. There are now some studies where you are putting suprachoroidal TPA to lyse the clot and do it fast. So this is excellent result. Usually we will have to put PFCL, we will have to milk the blood slowly. Probably there are methods where you are going in with an aspirator and aspirating out suprachoroidal. But the results are very variable. But this is an excellent result. Thank you for this. But there is no mistake here.
Doctors, and please collect your mementos from Augustine's
Presentation is Miracle Macular Hold. Mentee is Dr. Shivankar Sen, Vitreoretinal Fellow, Giridhar Eye Institute, and his mentor is Dr. Vishak Kumar, Consultant Vitreoretinal Services,